And have a huge treat for everyone today. We have Dr. Eric Kezirian, who is a professor at USC. He's an MD, a physician, a board-certified otolaryngologist, and a board-certified sleep medicine physician as well.
Wait, I'm sorry. What was that? What does that mean?
I can barely say it. Otolaryngologist.
It's a formal name for ear, nose, and throat doctors.
Right. Oh, got it. Okay. All right.
Everything up here. He's an expert.
Got it.
And sleep, which a lot of people, they wouldn't think those two things go together, but they are intimately associated, right?
They sure are. In fact, some people, of course, we're biased because it's our own field, but some people think that we should actually be the perfect people to manage sleep apnea, which is really the focus, snoring and obstructive sleep apnea, which is the focus of what I do. Right. But certainly we work in close collaboration with sleep medicine physicians that are often lung specialists, but can be drawn from a lot of other backgrounds. Right. Sleep medicine is one of these very exciting fields where people come into it from a whole different perspectives, ranging from pediatrics to internal medicine to pulmonary, so lung specialties, as well as psychiatry, neurology. And so it's a real nice melting pot. We have a lot of people with different backgrounds, and really it's important for sleep because there are all these different elements. So having people with different areas of expertise is pretty useful. And mine is primarily with surgery, but certainly have an awareness of the variety of other approaches that are used in treatment of sleep disorders.
Right. And it's just me, but like, I just feel like when I went to medical school, like no one even talked about sleep. It was like barely talked about for, maybe one day of one class somewhere. And now there's like a huge amount of awareness around sleep and making sure your sleep is optimize and you don't have sleep disorders and sleep apnea. I feel like the awareness is just through the roof right now. Do you feel that too? Or
Absolutely. Yeah. People always ask how I got into this field in the first place. And I was fortunate to go to medical school where they actually included it in the curriculum, the basic curriculum.
That's great.
And for a variety of reasons, I took a couple of twists and turns, but ended back with one of the things that really intrigued me because I felt like I could empathize with people that got a crummy night's sleep. And certainly awareness has grown. And some people put it as one of these 3 pillars of health with exercise, diet, and sleep. We're not totally sure if it's quite at that level just yet, but it certainly can make a big difference in people's health, but certainly their daily interactions in terms of getting, having the energy to get the most out of life.
Mm-hmm. Yeah, absolutely. I mean, I know for me personally, it is a huge pillar of my health. Like I couldn't get my weight under control. I couldn't get my blood pressure under control. I couldn't get my even nutrition under control. I was always hungry when I wasn't sleeping well. And when I really started focusing on my sleep, everything else just kind of fell into place. It almost came like I should have been doing that first. Mm-hmm. But, I grew up in a time where it's like sleep was considered a sign of weakness.
It's correct. Exactly. Right? We have these people that are very proud of getting through with 5 hours of sleep a night. Right. Of course, they're probably shortchanging themselves and probably making themselves a little bit more irritable than they could be otherwise.
Exactly. And I agree. Exactly. I think for me, that was the one thing that I did that moved the needle more than anything else. When I really started optimizing my sleep, I mean, everything across the board started improving. And it really kind of kicks off. It gives you the motivation, the energy to make all the other changes you need to in life to start optimizing.
Absolutely. Yeah. I mean, we don't live in a perfect world, and I have young children, so sometimes they have a tough night or whatnot. But certainly, I think we all feel the effect of not getting enough hours of sleep.
Exactly. So you probably see a lot of, we send you all of our sleep clients, people having problems with their sleep, whether it be sleep apnea or whatever. And how do you kind of think of the sleep patient when you see them? What's kind of your way of segmenting them into different diagnostic categories, if you will? Or how do you think about it?
Sure. Well, first we start out with just the overall sleep patterns. Right. Of course, we want to pick up people that are doing that 5 hours of sleep a night and coming in because they're not feeling refreshed, and we have an obvious answer there. But we want to get a sense of how well people are falling asleep, how easily, basically, how they're falling asleep, staying asleep, of course. All those things are important for getting enough hours of sleep. And then with what I do, which is focusing on this condition called obstructive sleep apnea, it's a disorder that really robs people of deep, good, restful sleep. So that's the quality of your sleep. And of course, there's many other sleep disorders that can play a real role in limiting that quality of sleep.
Right. And why is it important to treat your sleep apnea?
Well, so obstructive sleep apnea specifically is a disorder not just creating snoring sounds, because usually that's a big part of it, and that can be a main reason people get treated in the first place, but also because of this disruption of your sleep. Often when people aren't even aware of it, they're waking up repeatedly at nighttime, and so they're not able to get good, deep, restful sleep, leaving them tired, with fatigue, not doing things because they're just so tired they don't go out as much. And then, of course, if it's severe obstructive sleep apnea, there can be some health implications. And with obstructive sleep apnea, like some other sleep disorders, the way I or other people talk about the analogy as well is that people are having something of an adrenaline rush all night long when they're repeatedly blocking their breathing and waking up repeatedly. And that's why probably one of the mechanisms by which it's associated with high blood pressure and increased risk of stroke and heart attack, as well as early death. Now, that's severe obstructive sleep apnea. Milder forms typically don't really have that same clear-cut association, but certainly when it's severe, there are going to be the health implications, very more direct health implications of it going on.
How many people, what percentage of the population is affected by mild sleep apnea up to severe?
So milder sleep apnea is a little bit more common than, or notably more common than severe obstructive sleep apnea. Overall, the National Institutes of Health estimates about 20 million adults have obstructive sleep apnea.
Do you know what percentage is? Who's the mathematician?
So there are different ways you count it.
Right?
Yeah, it's a substantial group. And so basically one study that's now a little bit dated, but looked at people in the age of 30 and 60 years of age and found that it was about 4% of women and 9% of men. So it's a sizable group. It's a significant group. And that was the people who have problems with breathing, but also have symptoms during the daytime. If you look at just people who have troubles with breathing, it was even actually higher. So there's a lot of children, which I don't actually treat children, but it's certainly very common among young children. It's the most common reason children actually get tonsillectomy these days. But it's something that is for adults, even just limited to that, is 20 million, which is sort of a common problem, certainly.
And is it something that's acquired or developed over time, or do you have it from day one?
That's a great question. So the major risk factors for obstructive sleep apnea are being a man. It's more common in men than women, especially women before they go through menopause. So after menopause, once you correct for all the other risk factors, it's about the same, but men are more likely than women. Gaining weight is certainly a huge part of it. And unfortunately, sometimes it's the chicken and the egg because people aren't getting good sleep. So they're maybe eating more, they're not exercising as much. And so that can lead to weight gain. And then there are other risk factors, things like small jaw, big tonsils, other things that relate to the structure of the head and neck area. And those are things that we need to sort out when it comes to treatment.
Right. And the way I try to explain the problem to patients is that the back of your throat is basically closing in on when you're taking breaths, right? And so having a retracted jaw, having loose tissue back there, you just would have the support to maintain an open airway. Is that kind of a true explanation?
Yeah, absolutely. I mean, no matter what's going on, people usually breathe okay during the daytime.
Right.
Because their muscles are active, they're keeping their throat open for breathing. The problem is when we sleep, everything sort of relaxes a little bit, our whole body. And so that's where you get this collapse and blockage in breathing for various reasons in different people.
Right.
It's interesting. I never thought, because I thought of that before. Like, why wouldn't you have this impact during the day? But that makes a lot of sense.
Right. You're aware of it. And the drive to breathe is pretty strong when you're awake. The problem is you're trying to sleep and things just naturally relax.
Yeah.
So how would, like, if I'm just, someone doesn't know anything about this at home, how would I recognize in myself or my loved one who I'm sleeping with at night? Like, what would make me tell them to go get a test for sleep apnea? And then what are the tests for sleep apnea?
Sure. So the hallmark of obstructive sleep apnea is snoring. And we talk about disruptive
like everyone
snoring.
Snores, I feel like.
Well, sure. So that's why we qualify it by saying disruptive snoring.
Got it.
Snoring that's loud enough to wake up others. Now, obviously, some people are lighter sleepers than others. So snoring can be a little bit, I guess, not quite as loud and still be bothersome to others. But that's one of the hallmarks of obstructive sleep apnea, although not everybody has snoring, certainly. I think the biggest thing is if people aren't getting good, refreshing sleep, they're feeling tired during the day in spite of getting enough hours of sleep. That's something that there's, probably something going on, that they're not getting that quality of sleep that we might be looking for. And we certainly see patients that are coming in, for example, they've, got high blood pressure, that they're on 1, 2, 3 medicines that aren't working anymore. And that certainly could be going on with obstructive sleep apnea. I don't see as many of these patients, but people have had strokes. It's actually a fairly high chance of having some obstructive sleep apnea going on for various reasons. So there are some clues. And so typically when someone comes and sees me, the test to figure out whether you have obstructive sleep apnea is called a sleep study.
Right.
And there are 2 basic varieties. One is done at home and one is done in the sleep lab. For a couple of decades, really everyone got the one in the sleep lab, which was a very detailed and informative study. You were hooked up to a lot of wires, looking at brainwave activity, eye movements to look at the kinds of sleep you were getting. But from an obstructive sleep apnea standpoint, the real key was looking at breathing patterns and oxygen levels. There are other monitors that go with the in-laboratory tests. But the technology for home studies have gotten a lot better over time. And so it's a much simpler test. But the nice thing is it's not only cheaper, but you can be in your own bed. And you can have it probably be a little bit more natural because there's fewer monitors on you. You basically have a sensor in front of your nose and mouth to look at breathing patterns, a sensor in your finger to look at oxygen levels, and a belt around your belly, your torso, to look at the drive to breathe and that you're trying to breathe even if you're not breathing.
Got it. Yeah. I think I'd much rather be at home trying to do a sleep study than hooked up to that EEG machine. It seems like that would be hard to get a night's sleep anyway, but
I mean, there are pros and cons of each one of them. I think from a cost standpoint and just with the greater awareness and more people getting evaluated, the home sleep studies make a lot of sense. And they're for people that have primarily where we're concerned about obstructive sleep apnea, they don't have a lot of major heart or lung problems. They're really good tests these days.
Yeah. And so if someone gets a home study and it comes up positive for sleep apnea, do you still send them to do a formal sleep study or do you?
No, it's a diagnostic test. I mean, if they have it on a home study, sometimes actually the home studies understate the severity of someone's sleep apnea. So if they have it on a home study, we've got it. And we move forward to treatment.
Got it.
And what does that process look like because again, this is a pretty significant problem that I think most people are just unaware of if 5 to 10% of the population are affected by it. So if someone thinks that they may be affected by sleep apnea, the steps would be to find someone like where do they even begin? How do you find someone like you to do a study like this?
They can start with their regular doctor and they can certainly see someone who specializes in sleep medicine as well, either approach. Okay. I think the key that we've learned is that we want to have whoever sees them, whatever provider sees them, to document the reason why they would order this test, the sleep study. You wouldn't people don't just, shouldn't be ordering tests across the board for all their patients. It would be whether it's snoring, all the other things that we mentioned, a real reason to do it. And then they would have an in-person visit to discuss the findings and the next steps forward to go ahead and get treated.
Got it. And the at-home test is something the doctor would order, and it gets sent to the patient's house, and they do it themselves?
Sure. So doctor would order it. They would check with insurance about any needed authorization. And then often they actually go into the center to get some instruction about how to wear it at nighttime. It's fairly straightforward. There's some nice YouTube videos, and people always get that. But sometimes showing someone in person makes a big difference. So there are various companies that do send it out to patients, and it works pretty well. But it's if possible, it's a little nicer when they can go in and get some direct someone showing them, because it's very common for us. It makes totally sense for those of us who do this all the time, but for somebody doing it for the first time, it's obviously a little bit new.
Yeah,
makes sense.
Our practitioners at Next Health actually do the Stop Bang questionnaire. So that's a questionnaire for people who don't know that assesses, I think, 8 different symptoms and rates you as far as whether you have a suspicion of sleep apnea or not. And then we actually send people home with a WatchPat device to do a in-home kind of sleep study on their own to see if they have any indication of sleep apnea. Is the Stop Bang questionnaire something that you?
I don't typically use that per se, but those kinds of questions are very important.
Right.
The physician who developed that looked at it as a risk factor for people having trouble with anesthesia. And so it's a good way to screen patients.
Right.
But often I don't use that one specifically.
Got it.
You mentioned the WatchPat. So that's actually a little different and a fascinating technology.
Yeah.
So instead of having the sensors that are on your body, it's really just worn on your wrist and your finger. And so it's actually a pretty slick approach that has some strengths and weaknesses, but it's something that is a very good test and has been shown to have all the things that we'd want, being a valid check for whether someone has obstructive sleep apnea. So it's a little bit different than what I mentioned as far as the home test, but it actually works very well. It's a really nice option.
Oh, good. Awesome. So, when we see people with sleep problems, usually the way when I talk to people, I try to discern whether it's just poor sleep habits, an environment and just poor thought around how important sleep is. I would say that's like 80% of the people that we see. They just don't understand like the basics of getting a good night's sleep. Turning off electronics, making sure you have a colder environment, a dark environment. So a lot of times we can help people optimize their sleep just by making their habits better and making their environment better and just coaching them. And then we also use like a sleep monitoring device, like either a pad under their bed or maybe they have an Aura ring, those kind of things, so they can kind of track their sleep getting better. But then we also see a lot of people with insomnia. Okay, so they've tried everything and their brain is just on fire at night and they can't get to bed. And then we see the sleep apnea patients. So those are kind of the three categories of people that we see. So I wanted to get your kind of thoughts around each one of those. We talked a lot about sleep apnea, but what do you think about the whole concept of monitoring your sleep? Say you don't have sleep apnea, and just what are some of your tips and your big pointers around having a better sleep environment overall, or sleep routine or habit?
Sure. There's this whole array of things, and many of which the most important ones you already mentioned. But we talk about sleep hygiene, just like you brush your teeth for dental hygiene. So it's basically paying attention and doing some basic things of, don't read or watch TV in bed, cold environment, all these things that you mentioned have pretty regular patterns in terms of when you go to bed and wake up. And they can be very helpful. By themselves, they aren't great for taking care of people that have significant insomnia.
Sure.
And that's actually a very complicated approach. It's a multidimensional approach called cognitive behavioral therapy. And I'm actually not good at that. And there are actually a couple of programs that are available, even one available online, although right now it's a little tricky. You have to sort of have your company purchase a license for it for some reason. But there's a few of them out there. The one I prefer that had been probably studied the most is a little bit difficult for some people to access, actually. It's so crazy enough. But there are definitely a lot of practitioners, a lot of providers, both psychologists as well as physicians that do a nice job with cognitive behavioral therapy. But it goes beyond the sleep hygiene for people that have insomnia. Because longstanding insomnia is actually more of a biological problem, just like you're saying. Their bodies are revved up, and it's hard for them to sleep well. Both falling asleep and staying asleep can be really difficult for them. And it's something that you try to control it and manage it and really make it better. But it's hard. It doesn't make it go away completely, but certainly can help people quite a bit through this combined approach.
Yeah.
I don't personally use those monitoring devices. I think that they can provide useful information for people if they're making some changes, but it's something that it's hard to say, oh no, the Oura Ring or something tells me that I'm not getting enough deep sleep. You can't all of a sudden magically make yourself get deep sleep. So I think it may explain a little bit about what's going on, but if you're not getting enough deep sleep, you still have to go beyond that a little bit to figure out why, whether it is a problem like obstructive sleep apnea or a whole variety of other kinds of sleep disorders as well.
Right, exactly.
Don't you think that you can use that as kind of an indicator, though? Because at least that's how we use it, is if someone is, or personally, I'm managing my sleep hygiene and making little changes, and then I monitor my sleep, and I know if I watch TV or if I'm in my phone or, looking at social media or anything like that, my sleep is notably less deep than it would be other nights that I'm, if I do meditation before bed.
Sure.
So, then you're able to start making correlations and really perfect that sleeping process.
Absolutely. I mean, I think that I have a 4-page form that I have everyone fill out about sleep habits and patterns and really more symptoms like sleepiness and fatigue, and sort of getting a baseline and then doing things like paying a little bit more attention to your sleep and seeing how they feel. And I think really whatever you use, if that's helpful for people, there's this whole discussion of the quantified self. People like having information that's more objective. But I think it's also reasonable to just say how you're feeling in general. And sometimes it's actually loved ones that say, oh, their mood is a little bit better, or they're more interested in going out at night, or things like that can also be pretty important too. So really whatever works well for you. I don't know that you have to go one way or the other.
Got it. Agreed.
So let's dive in. What's the surgery for sleep apnea?
Well, the first
what's your treatment protocol?
Right. So it's actually, we don't start with surgery.
Yeah.
And I think that, there's a joke that I'm sure you're familiar with, that if you see a surgeon, you're going to get a surgery.
Exactly.
And that's actually not the case. I mean, that's the whole goal, is not to be like that.
Right.
And so the different categories of treatments for both snoring actually and obstructive sleep apnea, because I treat a lot of snoring too, there are 4 categories. The first category is what we think of as behavior changes. And sometimes they're not always simple things, but they range from trying to lose weight, if that seems to be playing a role in someone's snoring or sleep apnea. Often they'll say, when I gained that last 10 pounds, that's when things got pretty tough. And so it's a clue to roughly how much weight they might need to lose. Sleeping on your side or your stomach can be much better than sleeping on your back. About half the people with significant sleep apnea have a real improvement when they're on their side or
I
stomach.
thought sleeping on the back was the ideal way to sleep. Or is it like for one, but not for sleep apnea?
There's pros and cons. So if you talk to people that are like spine specialists and other kinds of orthopedic providers, they may talk about sleeping on the back being better, but I think from a sleep apnea and snoring standpoint, it's pretty clear that usually is actually worse.
Got it.
Than sleeping
well,
on
that's
your side
great
of your
news for me
stomach.
because I can never sleep on my back.
Neither
So
can
now I
I.
feel a little bit more validated.
Well, I mean, there's all
I
these,
sleep on my side all curled up. So
right,
I'm sure
there's on your side, and then you have the pillow between your legs,
Right,
and like all these
exactly.
kinds of things. I think that when people have spine troubles, they really obviously need to pay attention to those. They
Right.
should discuss it with their provider. But I think that in general, from a snoring and sleep apnea standpoint, side or stomach typically is a little bit better.
Got it. Okay.
And then the last thing that's in the conservative approach is I don't think people have to stop drinking alcohol entirely, but try not to drink it within about 3 hours of bedtime. We want it sort of out of your system before you go to bed, because alcohol adds to the relaxation of muscles that occurs naturally during sleep, and it makes everything really just ready to rattle around and snore and block your breathing a little extra. So we obviously start with those basics. In the first line, so then the first line treatment, as far as a real intervention for someone with obstructive sleep apnea, is actually not surgery either. It's called positive airway pressure therapy, or CPAP. And it's basically a machine that functions like an air blower. It doesn't give oxygen specifically, it just gives regular air. And what it does is it blows air through the nose or through the nose and the mouth together to almost like it balloons open the throat and prevents that collapsing and that blockage in breathing. And it actually works well for snoring too for most patients. And it really works well if you can sleep comfortably with it. So we always start out with it. We don't give up easily. We try to figure out what might actually be a little bit better for someone to be more comfortable with it. But the bottom line is they've got to wear it, and they've got to be comfortable with it. They can't just, be wide awake sitting in bed all night long with this mask on their face. They've really got to be getting some deep, restful sleep. And people do great with it. They do great. And I have friends that have sleep apnea, and some of them do great with it. But of course, there's some people that don't do well with it. And that's about a third of patients with obstructive sleep apnea who try it, that find it a little bit hard to wear with this mask on your face. And there's different mask styles and different ways that have improved things a little bit, but they haven't dramatically changed overall the fact that still about a third of patients have a little trouble with CPAP.
That thing is so huge. And it's like, it seems like that's like someone needs to innovate that thing. I think you need to innovate that thing.
Well, the person who developed it, actually, he's still alive.
Okay.
He's an Australian
Don't tell my Tom said
physician.
that.
No, it's funny. People that know him say that he thought there would be no way we would still be using this today.
Really?
But it does seem so archaic.
But it works well.
It
I mean,
works,
there's been, if you look at the old machines, there were these, industrial air blowers that were just, they'd rattle the walls. They were so loud, and things have really gotten a lot better. I mean, I think the way I explain to people is if you sleep comfortably with it, your approach is probably going to be, I wish I didn't have to wear it, but I like how I feel.
Yeah.
And if you want to sleep alone.
Well, right.
Not very conducive otherwise.
Well, right. Well, I mean, it's something, there's pros and cons. I mean, the sound of it, which they're a little quieter than they used to be, is probably better than the irregular snoring and choking that happens with some people with sleep apnea. So there's pros and cons. Yeah. There's a little bit of white noise. But I mean, it can be tough to wear for many people. And we don't tell someone they're a weak person because they can't sleep well with this. It's really, it can be tough. So,
and this would be, they would have to wear, I mean, if someone was given that, they'd have to wear it for life. I mean, it's like that's what you have to do for the rest of your life, is sleep with this mask on your face.
Unless something else changes. For example, if they are now able to have more energy and maybe lose some weight, that make the problem go away. So it can be a temporary thing. For many patients, it becomes more of a long-term treatment. And again, if you get used to it, then you're used to it, and you're ready to go. So the other treatments include both surgery and special mouthpieces called oral appliances. And the oral appliances are like double retainers, one in the upper teeth and one in the lower teeth. And they work by effectively holding your jaw forward a little bit. And that can be pretty helpful for patients. And people have to wear them and be comfortable with them, just like with CPAP. But some people find them more comfortable. Some people find them less comfortable than CPAP might be. We don't always have to do that before we consider surgery, but we would always want to start with CPAP just because it is so conservative. Oral appliances, they don't have any life-threatening risks, but there are some issues that can arise, issues with your teeth, issues with your jaw joint or TMJ.
Right.
And so anyway, we come to surgery. Yeah. So surgery has evolved quite a bit. And we talked about how we got into this field. So when I was a medical student, now over 20 years ago, there was one procedure available for sleep apnea.
And UPPP?
UPPP, the old-fashioned approach.
And
I
learned that one.
remember as a medical student, I mean, I one day I was, with one of the faculty members who's now a good friend, but basically he was saying, we have this surgery available for sleep apnea. And I said, surgery? Well, that's interesting. This is sort of, now I'm more interested in ear, nose, and throat. And I said, well, how does it work? He goes, not very well. But I mean, of course, he wasn't so flippant about it. But the idea is that you had one surgery that you would just sort of try it for patients and hope that it worked well, but it really didn't work all that well. And I thought, basically, I think we can do better. And so my career has been focused on not only, being involved in some new technologies that are available and certainly seeing some development of a lot of new procedures, but really in how we evaluate patients and figure out what kind of procedures might be right for them. So I think we've come a long way in 15, 20 years, and there's more options available for people that aren't doing well with CPAP. And surgery certainly can be a very viable option. And unfortunately, the results are better. And we've also learned maybe people that we shouldn't be operating on. So I think that's also, you wouldn't want to have someone go through a procedure with a relatively low chance of getting results we might want.
Right. Can you describe the UPPP surgery just for historical sense?
Sure. So there are different areas where people can have blockage in their breathing that contribute to sleep apnea. And one of the areas is the roof of the mouth, the soft palate. And so this procedure that was first described actually in 1982 involved taking out tonsils, removing the uvula, which is sort of that punching bag hanging down to the back of your throat, and a part of your soft palate. And basically the idea was take out tissue, take out stuff that can collapse and block your breathing and see if that clears things up. And it worked great in some people, especially if you had big tonsils.
Right.
It really worked well. But it didn't work well for a lot of people when they had other things that were playing a role. And one of the other things that can play a role is blockage of breathing down lower in the throat, behind the tongue, when there's sort of a few things that can contribute to sleep apnea. And so the nice thing is we've had not only newer techniques for the soft palate surgery to treat that area of the throat, but also other procedures to treat other areas of the throat and really, again, maximize results.
Got it. So is it less of an invasive procedure? Because that was a big procedure. You're removing a lot of tissue. Is a procedure less invasive now?
Well, yes and no.
Okay.
I think the traditional UPPP was painful not just because you're taking out tonsils, which if you're not a little child anymore, it is quite painful. But when you were cutting through muscle of the soft palate, it got to be pretty painful. That was sort of a double whammy.
Right.
So current techniques still involve taking out tonsils if people still have them. So that's still quite painful. But we can manage the pain because we're not doing so much cutting through muscle for most patients. Where the current approaches for soft palate surgery are based on moving things around and sort of anchoring them better, stabilizing things to keep the space for breathing open. And they actually work better than the more painful approach of just chopping it off.
So what's the name of the state-of-the-art surgery now for this?
So there are different techniques and there are subtle variations. They're basically based on this repositioning of tissue. One of the techniques is called, it's got an awful name, but it's expansion sphincter pharyngoplasty. But there's other ones. There's lateral pharyngoplasty, relocation pharyngoplasty. There's like an Australian modified pharyngoplasty. So there's subtle variations and subtle reasons why you might do a little bit different in techniques, but they all involve moving things around, and the differences are based on sort of what muscle you have to work with, these different muscles that you might move around and anchor it. And so, but the concept, there's a couple of different procedures that have been studied in pretty well done randomized trials compared to the traditional approach and actually get better results.
And do you customize which procedure each patient needs to have by kind of looking back there and seeing what's actually collapsing? Do you do that?
Sure, that's exactly what we do. You start with, in the office, a physical examination. In addition to asking patients a lot of questions about their sleep patterns, you want to examine them. And so we have the basics of looking in their nose, looking with tongue depressors inside their mouth. But as otolaryngologists, we have flexible telescopes that allow us to look through the nose and into the throat, trying to see what areas are more open, what areas are more closed, to get a sense of what might actually be blocking their breathing during sleep. The limitation is they're awake, sitting up in a chair in the office. Exactly. And so I've been fortunate to work with a couple of European colleagues and really advance the science on something called drug-induced sleep endoscopy. It's based on the idea that I joke with patients that I could come to their home with my flexible telescope and put it in their nose and watch their throat and sit there all night long hovering over their bed. But I'm sure they don't really want me to do that, and I don't really want to do it either. So instead, they can go to the operating room and get some sedation through an IV just to sort of take a nap. And if you do it carefully, it's actually somewhat similar to natural sleep. And we can look inside the throat then and get a sense of how things are collapsing. We do different things like put them on their side, on their back. Sometimes we lift their jaw to mimic what these mouthpieces might offer and come up with a plan that's sort of more tailored to them. The catchphrase of personalized medicine, which I'm sure you all practice here, is really important. The same is true for sleep apnea when it comes to surgery.
Got it. Interesting. I heard about just in my Google searches and just some of the stuff that comes in my way, I've heard about things like magnets being inserted and other pacemaker devices. Can you talk a little bit about those or where they are?
That's very funny. So I'm actually involved in the patent for this magnetic approach. I don't actually think it's going to work out well. I'm not really involved in the development anymore, but when I was up in San Francisco, there's a team and where we talked a lot about things. So I don't actually think that one is going to work out so well. But the pacemaker type approach actually is FDA approved. We were the first center in the Western United States to offer it. And I think it's a really nice approach. And the idea behind it is that the tongue falling back plays an important role in obstructive sleep apnea for many patients. And so there are different approaches that can tighten the tongue up. Sometimes you remove part of the tongue or do different things. But to really open up, the space for breathing behind the tongue, this approach of, it uses a lot of technology for pacemakers actually, of stimulating the nerve that controls tongue movement to move the tongue forward. And it really opens up the space for breathing really well, especially down low in the throat. But it also can work for the area behind the soft palate to open that up as well. So funnily enough, part of the evaluation for anyone considering this pacemaker approach is actually to get a drug-induced sleep endoscopy done, because that in the major study of it showed that it might select the patients that would do well or not do well with it. But there is one technology available. It's made by Inspire Medical Systems. It's called upper airway stimulation. But the exciting thing is that there's a couple of other companies that are working on this as well. One has recently completed their trial. We're just waiting for results. And there are a couple of other companies that are working on things that are in the pipeline that have been in various stages of trials. But one's available in the United States and in a couple of European countries. And they're making some progress in maybe a few other countries around the world.
Nice. So this is like a device that goes under your skin, and there's, I guess, a wire going to the back of your throat or something?
Absolutely. So there are three components to it. The main unit that goes over the pec muscle is basically like a pacemaker.
Got it.
But there are two wires that are connected to it. One wire, it's all inside the body, so it's a surgery to place it in the body. And the wires, one goes up to the nerve that controls tongue movement, roughly in the neck, and roughly right here in the neck. And then one goes down lower on the rib cage, between muscles of your rib cage, to look at breathing patterns. So that when it's on at nighttime and patients get a remote control to just hold it over and turn it on, and when it's on, when people are breathing in at night, that's when it sends a signal to move the tongue forward, because that's really when you need your throat open.
Wow. So for every breath, it's moving forward?
Every breath, right.
Wow, that's interesting.
Yeah.
I wonder if you could borrow the remote for someone else and...
That's exactly what I tell my patients. Don't worry, your spouse won't tell you to stop talking. Yeah. It doesn't really work like that.
Mute. Yeah. Interesting.
That's pretty incredible. So
it's pretty clever. I mean, the work has been done for decades, but I think the advances in technology, every aspect of the system has really improved. So it was started about 10 years ago that people picked up this idea again and got FDA approved about 5 years ago.
Well, it's great that there's some innovation happening, because all those surgeries sounded horrible.
Well, there's more I didn't even go into, but I mean, I think they're any procedure, who would want surgery, right?
For sure.
But
especially in the throat. I mean, it's such a sensitive area, and it's so hard. I mean, I'm sure the recovery process is probably not fun for.
So the main recovery for some of the more involved procedures is the first 2 weeks, especially. So it's pretty, it can be significant.
Yeah.
Of course, we control the pain and all that.
Sure.
But there are always risks of any procedure. I mean, the downside to having a device placed in your body is you have surgery. It's not quite as painful,
right?
But it's you have to maintain it and be used to it. And there's
of course,
some pros and cons of everything.
Yeah,
right.
And there's some limitations about MRIs that you can't get them for certain parts of your body, and some things to think about. But it's all part of tailoring to the patient, and it's some things sound very appealing to patients, and some people things sound terrible. And so you typically present a couple of options to patients of some of the trade-offs.
Yeah.
Some things might work a little bit better, but they have these features. And is that something that you want to pursue or not?
Right. Any other technologies that are out there that you see coming down the pike? Or?
Well, I mean, there are a lot of things in development, and part of the reason why there's been so much interest because obstructive sleep apnea is so common.
Yeah.
And also because nothing works well for everybody.
Right.
And so I think there have been a number of devices, in fact, quite tens of millions of dollars certainly spent in this area that haven't really panned out. And so there are a lot of things that haven't really worked, and so, I mean, there's more tens of millions of dollars in development of these newer devices and technologies. But the idea really, because it's such a common problem, estimated about 1 billion people worldwide suffer from obstructive sleep apnea.
Huge.
It's actually more common in Asian populations and other, different race and ethnicity groups can have different likelihood of having sleep apnea. So when you have a problem that's that common, we need something that's very accessible and affordable.
Right.
Yeah.
And so that's really been the push to make things less involved, so less of a recovery period from a procedure standpoint, but really less expensive and certainly just more, I would say palatable, but that's a bad pun.
Yeah. And so looking at this from a natural standpoint, it seems to be like weight loss is one of the main components that could affect it. Is there anything else that you advise your patients on what they could do to try to manage this naturally?
Well, unfortunately, I mean, there's not a lot of great things. It's not purely just sort of where things are blocking. There are some other things that are more biological. Some people, for example, the way their breathing patterns work, it's little things become big issues, if that's a better way of putting it, that control their breathings a little bit.
Right.
And that's just part of who they are.
Yeah.
Now, we can change some of these other traits. There's an interesting study presented at a European meeting earlier this year from a group in Boston, looking at a couple of medications that actually had really nice results. And there's a company formed along these lines. A lot of the medication studies have not panned out, but this company that's formed along these lines is called Apnea, and it's exploring this. They're going to probably use different medications than what was used in the study because there were some side effects, but I think that medications and maybe even oxygen may have a role, whether on their own or I really think in combination with things like procedures or oral appliances, these mouthpieces. Again, for people that can't use CPAP, because right now that's still probably the lowest risk option for people if they can tolerate it well.
Got it.
How would those medications work?
So yes, one of the it's actually a diuretic, a water pill called acetazolamide.
Yeah, of course.
It's used for altitude sickness, and people at altitude, they have more irregular control of their breathing. It has to do with the acid-base balance in their body. And in fact, some people have this even at sea level, that they have an irregular control of breathing. So you get some blockage in breathing, and instead of sort of quickly coming back to normal, the some blockage of breathing can become more magnified, and they don't recover back to normal as quickly. So actually this medicine, just like altitude, it helps correct breathing patterns. It can actually stabilize things.
Interesting.
There are some people that wake up too easily. They get little blockage of breathing, and for some people, they'll sleep right through it. But if you wake up too easily, you're waking up all the time, even with subtle blockage of breathing. And that's something that we can't easily control except by giving people, different sedatives, something like Ambien.
Yeah.
Some people have trouble with Ambien, or even the shorter acting ones. They feel a little tired. They have a hangover effect in the morning. And so that may or may not be a good long-term option. There are other ways to sort of change these characteristics. And I think we're getting to the point where we might be able to figure out what actually, because different people have different factors playing a role in their sleep apnea. We're getting to the point where we might be able to start figuring out. I mean, 5 years ago, we thought it would be 5 years from now. And so we keep saying in 5 more years. But to really tease out some of these other factors that are playing a role, going beyond just this, hey, I've got big tonsils or something else just physically collapsing it, that there might be some other things playing a role to enhance the results of, again, these treatments like surgery or mouthpieces.
Yeah. Interesting. We skipped one big category. What about nasal valve problems in the nose area? What you see these strips at the pharmacy, the pieces of tape you put on your nose to open up your valve. They seem to work okay for some people, right?
They can work well for some people. Right. Absolutely. It's pretty unusual for nasal blockage by itself to be a key part of obstructive sleep apnea, but it's possible, especially if people are thinner, if they have bad blockage in their nose. And so getting their nose open can make a huge difference for them. Things like the Breathe Right strips or other similar things have been approved for snoring, and they can actually make a big difference for snoring. So that's part of what goes into it. And what part of the physical exam is, honestly, I just look at people, ask them to breathe through their nose. And those people that have a lot of claps on the sides of their nose, that's when the Breathe Right strips are sort of an obvious thing. There are procedures available for that, but really, you start with simple. And so Breathe Right strips, or there are something that tuck inside the nostrils that can actually be very helpful and do some of the same kind of thing, just opening up that nose. With my big nose, I don't have that problem.
I've tried the Breathe Right strips before, and because I don't have a valve problem, did not help me at all, of course. So I think you're right. Like, you really got to make sure someone's examining you before you go out there and buy all sorts of stuff and try all these things and waste your money and time sometimes, because really those are for specific problems. So.
Well, I mean, certainly I see that. It's a lot of frustration.
Yeah.
People say, I've had this going on for a long time. I've tried, 10 different things that are, available there, different things to help me sleep better. It hasn't worked out. They almost give up. But, fortunately, when I see them, they haven't totally given up. So we can then do it. But certainly sleep and sleep aids is a, big, lots of money spent to help people sleep better in this country.
Yeah. Why were you doing breeze right strips? Do you snore?
Before, when I weighed 30, 40 pounds more than I do now, I was snoring every single night. Like my wife would want to like kick me out of the house and sleep in a different house. I'm like, I got to fix this. So I was trying all sorts of different things. There was a pillow that actually, like every time you snore, it moves your head.
Oh, wow.
Yeah. It's so, all sorts of different devices out there that people sell on infomercials in the middle of the night.
Got it.
Yeah. A lot of people spend a lot of money, and I guess these companies do well. But it's funny because I'm actually in the middle of writing something talking about all these things that are marketed, and honestly, I have some really big, prominent names in the around the world in sleep medicine that are also have seen this proliferation of devices out there that are being advertised sort of surreptitiously for sleep apnea and snoring that really don't have anything showing that they provide benefits.
They're just selling the dream.
They're selling the dream, exactly.
Another pun.
So they sleep jokes today.
So they can live the dream, I guess.
Yeah, exactly.
Exactly. No, I mean, you see stuff in like infomercials all the time now on your Instagram feed too, like people selling stuff for sleep apnea that seem to have no basis in science or reality, some of them,
Right. No, it's very frustrating for patients when they come in and say, listen, I was told by somebody to try these things, and sometimes things that are procedures that are very involved and expensive and all this kind of thing, much more than whether it's a pillow or something, less involved. But it's like everything, it's people out there that are, advertising things that aren't necessarily supported by any real evidence. So.
Right. And, the thing I try to drive home to all of our clients and our patients is if you have sleep apnea, you got to get it fixed. You can't just live with it. First of all, the quality of your life is decreasing every year you live with sleep apnea, and your chances of getting metabolic syndrome, heart attack, stroke, even Alzheimer's. I read papers like, dementia just keep going up every single year you live with this problem. And obviously, the obvious solution to a lot of this is try to lose some weight first. But like you said, it's a chicken and egg thing. Like you can't lose the weight because you can't get any sleep because you have no energy. And it's a vicious cycle, right? So I think it's extremely important for the people that are listening and all of our clients that if you have sleep apnea, to see someone like yourself and try to figure this out.
If you feel like you may possibly, if you couldn't figure out why you're always feeling so tired, I think that's the key because most people don't know.
Right.
So they've got to take that first step to figure out, like, is this affecting me or not?
Right. And absolutely. And there are some people that for various reasons they've gotten a test. The only difference I would say is if they have pretty mild sleep apnea and they're not snoring a lot to wake up anyone else, they're not tired, they don't have other obvious health concerns, probably can just watch it.
Yeah.
But absolutely, there's people that have been dealing with this for a long time and they've wondered why they're suffering for so long. And I think that oftentimes they've tried, for example, the CPAP, and it wasn't comfortable for them, and they just think that's the end of the road, that there's no treatment available. But I think that there are other options, and to really get people getting their life back. Basically, it's not just whether it's getting older. There's actually things that we can really get people feeling better and doing better.
What percentage of people who come in with sleep apnea are you able to cure of it?
Cure is a strong word. I think that we can have absolutely fantastic results. I think what we think of when it comes to surgery, just like with these mouthpieces, is that we want to cut the severity of their sleep apnea at least in half and take them to having no sleep apnea or mild sleep apnea.
Okay.
And so that's, managing it pretty well. And I think that an estimate I would give you is probably about 70% chance of getting those kinds of results.
Okay.
Some things are a little bit better. Certainly some patients have a better chance of getting there than others. But I think that's what we're looking for when I, go to the operating room with someone is to have that good chance. And even if they don't get all the way there, they can often have real improvements.
Sure.
And I see a lot of people that haven't had good results after previous surgeries. So we don't give up easily. We get a sense of, hey, why did we not do well? What might we do to get you over the hump to really get you that kind of result? So I see a lot of people that have never been checked out for sleep apnea at all. And so ordering tests, but also people that have been through, different surgeries before where they didn't quite get the results. And certainly, unfortunately, happens in some of my own patients, but we keep going and we don't necessarily always have to do more surgeries, but we want to figure out what's going to, be options for getting people feeling as good as they should be.
Yeah.
Right. There's another category of kind of sleep disturbances. I don't know what you call the category, like restless leg syndrome we were talking about a little bit earlier. What are your thoughts around that category? So what is that called?
Well, I mean, there are all these kinds of sleep disorders, and there's so many categories. Restless leg syndrome is a very common sleep disorder that is associated with, it's this thing that if you haven't heard of it before, it's actually people classically describe legs. So it's leg discomfort, not real pain, but discomfort that almost can feel like a creepy crawly feeling. Typically worse at night, gets better with people moving their legs. And it's something, for example, if someone go to a movie, you ask them if in the evenings, can they sit still, or are they bouncing their legs the whole time? And so people have this problem, and sometimes it's not a major concern, but if it interferes with their falling asleep, or if the discomfort wakes them up at nighttime, then there can be treatments. And the medications actually used to treat it, because it's not a surgical treatment, but the medications have changed. There used to be a certain category of medicines based on the chemical in the brain called dopamine that actually seems like there are some problems that people run into with that more and more. So there's actually a couple of different kinds of categories of medicine that are being used more prominently, and sort of the opinion has changed a little bit regarding that.
So what was it like? If you have less dopamine, you have a higher chance of having it, or
it has to do with,
or is that not even connected?
Yeah, it has to do with the neurons in a certain part of the brain not being able to receive the dopamine, and so you basically make more of it available to them.
Got it.
It's a little bit more than just that, and honestly, it's a thing that I really don't actually treat so much anymore. I studied it for my board exams, but I'm ashamed that the exact pathophysiology, I'm just blanking on it at the moment. But that's the medicines actually increase the levels of dopamine. So they make it more available to the body. And so I'll refer them to a colleague in sleep medicine who really does a lot of this, and be able to monitor them going forward. There's, again, a whole slew of sleep disturbances ranging from what we call parasomnias, which are things like sleepwalking, or certainly children have night terrors and all these kinds of things. So seeing someone, if your sleep isn't normal, and especially some of these things can cause risk to the person, you have to really be careful about safety purposes. There's something called REM behavior disorder, where people almost act out their dreams at nighttime, and they can actually be safety risk for themselves or for others. And so there's quite a few things to consider, and sometimes checking in on them involves tests. Sometimes it really is just based on what you feel. I could go on and on. Narcolepsy, cataplexy, all these different kinds of things that are important. That's part of why I have this extensive form that people fill out when they see me, because we want to tease out whether someone's tired because of some other reason, or whether obstructive sleep apnea might be really what's going on, explaining why they're not feeling good.
We have a friend actually who has central obstructive sleep apnea. What is that? Can you talk about that a little bit? Where he doesn't really have any. Well, you tell us about it.
Sure. So there's central sleep apnea, and there's people that have central and obstructive sleep apnea. We call it mixed sleep apnea, or sometimes called complex sleep apnea.
Okay.
So central sleep apnea is basically when people aren't breathing as much as we think they should, and it's because their brain isn't sending a signal, or they're not having this, they're not trying to breathe. Whereas obstructive sleep apnea, they're trying to breathe, they're just having the breathing blocked. And there are different treatments. And CPAP can actually work well for both categories of obstructive sleep apnea. Both categories of sleep apnea. And while we might consider surgery or mouthpieces for obstructive sleep apnea, they don't really work well for central sleep apnea, because that's not the primary issue going on. Sometimes central sleep apnea is from some very basic things like acid reflux actually can contribute to some central sleep apnea. Sometimes with people taking pain medications, for example, for back pain on a long-term basis, that can cause some central sleep apnea. But sometimes it's just sort of how you're made, and it can be actually something you don't need to treat, but certainly if you're tired, treatment can be very helpful, and that's often involves positive airway pressure therapy, like CPAP.
So CPAP is also the treatment for central sleep apnea.
It can be, but there's some more sophisticated approaches that use positive pressure that can be necessary when we're dealing with a lot of central sleep apnea. So you often will start with the basic CPAP, but if that doesn't work well, there can be these more advanced approaches, but they're somewhat similar, but they're a little bit different, a little bit more sophisticated.
I see. And just real quick on the insomnia front, CBT, cognitive behavioral therapy, what is that? I mean, is this seeing a psychologist, and do you tell us what that is a little bit?
Sure. So CBT, there's these different components to it.
Okay.
Everything from stress reduction, sometimes sleep restriction. So people say that I spend 12 hours in bed every night and I'm still feeling tired. It's like, well, how much are you actually sleeping? And so people, for example, if they're only sleeping 5 hours, well, you start actually with a very difficult plan of saying, okay, you're going to spend 5 hours and 15 minutes in bed. You're not going to nap. you're going to be exhausted because maybe you only slept 2 hours of that 5 hours, but you're going to be exhausted. So the next night, hopefully, you'll probably sleep for 3 hours. And then you go through it until you sleep most of that 5.5 hours. Then you'll go to 5.5, 6 hours. And so you'll add 30 minutes at a time. And the idea is to go through this process. And again, it's not easy for many patients where you're actually spending more of the time actually sleeping that you're in bed.
Right.
So that's, again, one of these other components to it. Certainly, sleep hygiene is important. There's a few other aspects to it, but it's a multidimensional approach, and it does require time to work on these various things. Some aspects of it are more helpful for the other patients. So either going to a provider that really does a lot of this, whether a psychologist or a physician or other provider, or there is a couple online programs that actually are not terrible. Yeah. They're actually been studied, and they can certainly help with that, because sometimes typically because these programs that take some time, they involve so many visits, and it's a little bit hard for patients to keep coming back and all that. So having this online resource for people, these online programs can actually be pretty helpful for people with, I guess, keeping on the track.
Right. Interesting. Very cool. I feel like I learned a lot about this whole
absolutely. I didn't know how extensive it was, and that's true. I didn't even think about all the different categories. I actually used to sleepwalk when I was a kid, but that's true. I mean, there could be so many different things that are impacting your sleep that it really might not be sleep apnea.
Right. I mean, the last thing I want to do is surgery for sleep apnea when that's not the main thing that might be explaining someone had it. It might be a red herring. And that's part of why being board certified in sleep medicine is helpful, to have enough knowledge to be dangerous, just enough knowledge to identify these things, certainly that we can work on them before thinking about procedures if we're going to go down that path.
Yeah. So one more question might be unrelated, but I was thinking about it. What about narcolepsy? I mean, just since we're on topic of sleep, what causes that? Because it's just so interesting to me.
Right. So narcolepsy, there are a couple of different reasons why people have it. It can be related to what's called HLA. It's the sort of your genetic makeup puts you at higher risk for it. There are other explanations for it. But the disorder itself involves being really tired. And while people can be tired with obstructive sleep apnea, we worry a little bit about it when people are really, really tired. And they classically describe what are called sleep attacks, where they might be sitting here talking, they might be driving, and they need to fall asleep right now. Wow. And they'll pull over the side of the road and need to sleep, and they'll wake up and they'll feel actually pretty refreshed, which is different than obstructive sleep apnea, where they get in crummy quality sleep. So they wake up from a nap and they don't feel very refreshed at all.
Yeah.
And so there is a test for it. Sometimes it doesn't even involve the test, but there's a test for it that basically involves people taking naps during the day. And if you go quickly into deep sleep, rapid eye movement, or REM sleep, that can be a sign that you have some narcolepsy going on. But some people with narcolepsy have this problem called cataplexy, where they just suddenly will be talking, and actually with laughing or other strong emotions, they'll just sort of lose muscle tone. And so they'll just slump into a chair. And their brain, they'll actually won't lose consciousness, but they'll be completely have lost muscle tone, and they'll collapse.
Wow.
And they'll look like they've passed out, but they'll actually be aware of things. And when they have that, it's like, well, they've got narcolepsy with cataplexy, and people will get treated. And the treatment primarily is use of stimulants. And it's actually, the GHB, the date rape drug, is actually a treatment for this, even though it's a sedative. And so because of all the, implications of that, that's available from one pharmacy only in the United States to get that. So it's something that there are stimulants, there's other, medications to make your sleep a little bit better. And so there's a whole array of options. Again, that's not something that I would start someone on. I would really refer them to one of my colleagues.
Got it.
You probably get this question a lot. What about CBD and sleep?
So CBD, it probably works well. I mean, to the best of our knowledge, it's reasonably safe. People have actually looked at it a little bit for obstructive sleep apnea, and probably in combination with another medication, just like I mentioned, one medication, a study that looked at a combination of two different things. It may actually be beneficial for sleep apnea. Now, it probably helps with sleep in general, probably makes people not wake up so easily. Right. And again, that may be a big part of what's going on for some patients. And so that's why CBD can be quite effective for some people. I don't prescribe it across the board or recommend it, but if someone's using it, typically they'll have come to me using it, and they'll ask about it. And I say, in moderation, it's probably okay. I mean, I wouldn't be, using large amounts over long periods of time, probably as sort of the crutch to get you to sleep. but everything in moderation probably is okay.
Right. I think that's one of the big issues with CBD right now is no one really knows what the dosage is, and everyone's just kind of it's a wild west right now.
It's wild west, absolutely. And so there hasn't really been that much research in it, but I think that it's probably not so harmful.
Yeah, awesome.
I mean, it's a little bit of a sedative, just like things like Ambien are. And the Ambien has its own problems, but I think that these things are used quite a bit, and similar kinds of substances have been used.
Sure.
Again, in moderation, it is probably pretty safe.
Well, very cool. So for people that are listening to this podcast that want to see you about a sleep apnea problem or any just sleep issue, how would they contact you? How would they find you?
Well, they're certainly welcome to go online and to reach out to me directly by email.
Okay.
Certainly they can schedule an appointment. I'm at Keck School of Medicine and Keck Medical Center of USC. So there's can schedule directly.
Great.
But many resources. I'd be happy to talk with them and certainly see them as patients.
Thank you. We really appreciate you coming by here today.
My pleasure.
It's been such a great conversation, and I think we've all learned so much. And we look forward to working with you and sending you all of our sleep apnea patients.
Well, thank you very much. I look forward to working with you more and more going forward.
Great. Thank you so much. Thank you.